Alright, so let's talk about spleen here. Now, for the location of the spleen lies in the left hypochondrial region and in a bit of epigastric region as well. Now, as you can see in this diagram, this region right here, the one I'm shading, is the left hypochondrial region. So, the majority of the spleen lies in this region, but a bit of spleen extends into the epigastric region as well. So now we have some values for the spleen, and you can remember it by the odd number formula. So the spleen is 1 inch thick, so 1 inch thick, 3 inches broad, 5 inches long, 7 ounces in weight, and it's related to 9th and 11th ribs. So 9th and 11th. So as you can see, these all are odd numbers: 1, 3, 5, 7, 9, and 11. Okay, so 1 inch thick, 3 inches broad, 5 inches long, 7 ounces in weight, and related to the 9th and 11th ribs. Now, for the external features of the spleen, we have two ends. We have two ends of the spleen, three borders, and two surfaces. So the two ends will be, of course, anterior and posterior. The three borders will be the superior border, the inferior border, and between them lies the intermediate border. And the two surfaces will be the diaphragmic surface related to diaphragm and the visceral surface related to the visceral in on the posterior side, right? So now we come to this diagram. As you can see, this we see two angles here, the antero-basal angle and the posterior-basal angle. So we'll talk about this in a minute. Let's move to the external features of spleen. Okay, so in this diagram, as you can see, as I told you, it has got three borders: a superior border, a inferior border, and the intermediate border is not shown here. It will be like something this. Okay, so and the two ends, the posterior end and the anterior end. Okay, so it's the diaphragmic end, and opposite to that will be the visceral surface. Okay, now for the features, we have the superior border. As you can see, the superior border is very thin. When you look in the dissection hall, the superior border is very thin and it is convex. Okay, and the one thing to note is that you'll find various splenic notches on the superior border. So this is a characteristic of the superior border, that you'll find various splenic notches. Okay, so this was about the superior border, and here we have the inferior border. Okay, and now for the interior end, it will project downwards, forwards, and towards the left. As you can see, downwards it will be forwards and towards the left. Okay, and it is broad and related to the Frenetico ligament. Now what's the Frenetico ligament? We'll talk about that in a minute. And here you can see these splenic notches, which is a characteristic of the superior border. And as you can see, the posterior end is kind of blunt and rounded as compared to the interior end, which is broader than the posterior. Okay, now when we talk about the relations of the visceral surface, on the back side we have three major impressions, and those are the gastric impression for the stomach, the colic impression for the splenic flexure of colon. So the colon will be going something like this. So this is the splenic flexure, and we have the renal impression for the left kidney. Okay, so again, as you can see, it's the inferior border, superior border with these notches, and this was the border I was talking about, which was not shown in the earlier diagram. This is the intermediate border. Okay, and this is the posterior end right here, and this is the hilum of the spleen with various splenic vessels, and the pancreatic impression will hold the tail of the pancreas, right? So now let's read about it. The spleen is surrounded by visceral peritoneum. It's a peritoneal organ, except, now this is a very important point here, that it's not surrounded by peritoneum in the area of hilum on the medial side of the spleen. So the hilum side is not surrounded by visceral peritoneum. Okay, so the splenic hilum, as it's the entry point for various splenic vessels, occasionally the tail of the pancreas reaches this area, which forms the pancreatic impression as well. Okay, now as in this diagram also you can see, here we have the lesser omentum, the stomach, and this is our spleen. Okay, this is our spleen right here. Now this ligament, as you can see, connecting the stomach and the spleen is the gastrosplenic ligament, carrying the short gastric vessels, and the ligament connecting the left kidney with the spleen is splenorenal ligament. This is the splenorenal ligament carrying the tail of the pancreas and splenic vessels as well. And here you have the left kidney. Okay. So now we come to Frenetico-Colic ligament, the ligament which I talked about in the earlier part. Now what's this? Basically, Frenetico-Colic ligament limits the upper space of the left paracolic gutter. This is the colon right here. So what will be this space? This space will be the paracolic gutter, right? So it's limiting the upper area of the left paracolic gutter. So whenever there is an enlargement of spleen, the spleen never goes to the left paracolic gutter or the left region. Instead, it extends towards the right iliac fossa, right? So it's the Frenetico-Colic ligament. Remember, it is not attached to the spleen, rather it's attached on the diaphragm and on the splenic flexure of colon, right? Okay. So again, in this diagram, you can see the visceral relations, or rather the peritoneal relations, I'd say, I'm sorry. So in the peritoneal relations, first of all, you'll have this major big organ, which is the left kidney. Along lies the left suprarenal gland. Okay, and here's your spleen with the splenic vessels, the splenic artery and the splenic vein. Remember a point about the splenic vein, that the splenic artery almost runs in front and in line with the pancreas, but the splenic vein runs behind the pancreas. This you need to keep in mind. Here you have the splenic flexure of colon, the tail of the pancreas, which extends towards the hilum of the spleen. Okay, this is the hilum and this is extending towards this region. And yeah, so this was about the peritoneal relations of the spleen. Now we have something known as the avascular plane of the spleen. What's that? How will you determine the avascular plane of the spleen? Okay, so when we keep spleen in this anatomical position, here you'll have the 10th rib. Okay, this will be the ribs, and if you draw a long axis along the 10th rib and make a plane which divides the spleen into two equal halves, the two superior halves and two inferior halves. So this plane dividing the spleen exactly into two equal halves, the superior and inferior, this will be the avascular plane. Okay, so whenever you have to give the incision on spleen, the surgeon prefers to give the incision on the avascular plane. Okay. Now let's study about the accessory spleens or spleniculi. As we know that spleen is made up of many small accessory spleens or spleniculi. They can also be found in various other places. The various other places are majorly the derivatives of the dorsal mesogastrium. The dorsal mesogastrium, what's that? If you have the stomach here, the spleen, so this is the dorsal mesogastrium, the ventral part and the dorsal part. Okay, so what are its derivatives? We have studied in this diagram also. What will be those? The gastrosplenic ligament connecting the stomach and the spleen, the lienorenal ligament connecting the spleen and the kidney, the gastrophrenic ligament connecting the diaphragm with the stomach, and of course the major part, the greater omentum. It can also be found in the spermatic cord, but remember, in females may be found in the broad ligament of the uterus. Please don't confuse it with the round ligament. Many students see, okay, chalo, that it's the spermatic cord in male, so what will be in females? The round ligament, but no, it's the broad ligament of the uterus, remember. Okay, so now we have a clinical point here. As you know, the smaller branches of the spleen, the hilar branches basically, those are the end arteries. Now if there is any obstruction or clot, basically emboli in those end arteries, what will happen? It will result in splenic infarction. What's an infarction? It's basically the death of tissue. Okay, so if such condition happens, there will be a referred pain in the left shoulder. Remember, there will be a referred pain in the left shoulder, and this is known as the Kehr sign. Why there will be referred pain in the left shoulder? Because of the common nerve supply of the spleen and the left shoulder. Okay, in this diagram also you can see if there is a splenic infarction here, the pain will be referred to the left shoulder, the splenic pain. Same goes with the splenomegaly. Now some extra points here to be remembered. The spleen is tetrahedral in shape and it is normally not palpable. You cannot palpate the spleen in the normal physiological conditions, right? Okay, so now we talk of the anterior-basal angle and the posterior-basal angle, thing which I talked about in the initial segments. Okay, so what's the anterior-basal angle? It's the angle between the superior border with the lateral or anterior end. And what will be the posterior basal? It will be the junction of inferior border with lateral and or anterior end of the spleen. So anterior basal angle is the angle between the superior border and the anterior end. And what's the posterior basal angle? It's the angle between, or rather the junction, I'd say, between the inferior border with the anterior end of the spleen. Okay, now the one thing to remember about the anterior basal angle is whenever the spleen is enlarged, this angle is first felt. Okay, you cannot feel the posterior basal angle, but in case of splenomegaly, you'll first feel the anterior basal angle. That's why this is also called the clinical angle of spleen. Clinical angle of spleen, anterior basal angle. In this diagram, now you can, I guess, well visualize. This is the anterior basal angle right here. Okay, between the anterior end and the superior surface. This one, this angle right here, and the posterior basal angle is this one, between the inferior border and the anterior end, this angle. Okay, so these two angles you can see here. All right, now let's move forward. Here you can see a well labeled diagram of the spleen. So in front you'll have the diaphragmic surface, and what's all of this? This is the visceral surface, right, which will be in relations with the visceral organs. Here you have the upper pole of the spleen, the lower pole, the visceral surface, all of it, and hilum, giving place to various splenic vessels. You can see the splenic artery and the splenic vein right here, and it is devoid of visceral peritoneum, remember. Now you can clearly see the impressions too. What will be this impression? This is the gastric impression. What will be this impression? This is the colic impression for the what? Splenic flexure of colon. And what will be this? It's an impression of renal impression for the left kidney, right? Now some more points about the Frenetico ligament here. As I told you, the Frenetico ligament, it is not attached to the spleen, and rather it limits the upper end of the left paracolic gutter. As you can see, this is the left paracolic gutter, and when the Frenetico ligament is connected here, it basically limits this part. So if there is an enlargement of spleen, it will not go to this area. Why? Because there is this ligament. Rather, it goes to the right iliac fossa here, right? So the same thing is written, but and please remember its other name too. The Frenetico ligament is also known as sustentaculum lenis. Sustentaculum lenis is the other name of Frenetico ligament, right? And if we talk about the diaphragmic surface here, which is in relation with the diaphragm, it separates it from what? It is, as you can clearly see, the diaphragmic surface. It is separating the spleen from the 9th rib. This is the 9th rib, 10th rib, and the 11th rib. Okay, as I told you in the earlier sections, it's relation with the 9th and 11th rib. Remember the odd thing. Okay, and it also separates it from the costodiaphragmic recess. Right, now let's read about it. The diaphragmic surface related to the diaphragm separates the spleen from the costodiaphragmic recess of the pleura, the lung. Here you have the left lung, and the 9th, 10th, and 11th ribs. So if you remember this diagram, you can clearly remember that from what things the diaphragmic surface separates the spleen from. Okay. Now, if we talk about the arterial supply of the spleen, or basically the circulation, what points you need to remember? Now, there are a couple of theories to understand the circulation. Okay, so let's take them one by one. According to the closed theory of the splenic circulation, the capillaries which are coming, okay, the capillaries, they will be in continuation with the venous sinusoids, okay, and they'll continue to the vein. That's what it's written. The capillaries are continuous with the venous sinusoids, so they are basically joined in close proximity, okay, which lie in the red pulp, and the sinusoids then join to form veins. Okay, so as the name suggests, if we talk about the closed theory, they will be in close proximity with each other, and when two things are in close proximity with each other, they tend to join. That's what it's written. But in the open theory of splenic circulation, the capillaries end by opening into the red pulp. They blindly open into the red pulp, it supplies the substance of the spleen, and then from the red pulp the blood is collected and it enters the sinusoids through their walls. So it's not a direct relation of the capillaries with the sinusoids, but rather the blood enters the sinusoids through their walls. Okay, now there is another theory, the third theory, which is the compromise theory. It says when the circulation is open in the distended spleen. Now it's very common sense. When the spleen is distended, the vessels will not be in close proximity with each other and the blood will end into the substance of the spleen. But rather, if the spleen is contracted, in a contracted spleen, the capillaries and venous sinusoids will be in close proximity with each other and they'll join to form a connection, right? Now, if we talk about the lymphatic drainage of the spleen, remember there is no proper lymphatic drainage, but a few routes from the connective tissue of the capsule. Okay, so from the connective tissue of the capsule, a few lymphatics arise and it will drain to the, what's the major lymphatic node? In that, it's the pancreatico-splenic lymph node. Majority of the structures drain to this, and spleen is no exception. So it drains into pancreatico-splenic lymph nodes, which lie along the splenic artery, right? It's an important point to remember that pancreatico-splenic lymph nodes lie along the splenic artery, and what drains into that? The lymph from the connective tissue of capsule of spleen. Okay. Now we have some clinical points here and then we'll be done with the lecture. Now, palpation of the spleen. As I've told you that the spleen is not normally palpable, but palpable if enlarged. So an enlarged spleen can be felt under the left costal margin. Left costal margin, if the spleen is enlarged, or rather it becomes twice or more than twice its size, only then you can palpate. Okay, note that the spleen becomes palpable only after it has enlarged to about twice its normal size. Okay, so how you'll palpate the spleen? You can't palpate the spleen when the patient is lying in the prone or supine position. Okay, you'll have to turn the patient to the right side. Of course, spleen is lying on the left side, so you can't turn the patient on the left side itself. So how will you palpate? Okay, so palpation of spleen can be done by asking the patient to turn or rather lie on his right side, so you can easily palpate the spleen. Okay, so as you can see the splenomegaly here, this is the mild enlargement till here, the moderate enlargement, bit more enlarged, and a severe enlargement. Now in very severe cases it can reach up to the right iliac fossa as well. Okay, so splenomegaly, what do you understand by megaly? Megaly is enlargement. Okay, so splenomegaly is enlargement of spleen, right? So if the spleen is enlarged, it can project towards the right iliac fossa in the direction of axis of 10th rib. Okay, don't forget the axis of 10th rib. We also talked about while talking about the avascular plane. Okay, and the notches of the spleen are easily palpable. On which border did these splenic notches lie? On the superior border. And these notches itself are very palpable in case of splenomegaly, right? And don't forget the anterobasal angle, the clinical angle, which becomes enlarged primarily rather. Okay, now if we talk about splenectomy, what do you understand by splenectomy? It's the removal of spleen, surgical removal of spleen basically. Now, as I told you that the tail of the pancreas may lie in the pancreatic impression on the hilum of the spleen. So the surgeon has to be very careful while doing the operation as not to damage the tail of the pancreas. Okay, so it has to be carefully avoided as it is very rich in alpha and beta cells, so it can lead to idiopathic diabetes mellitus as well. Okay, so as we know the spleen has two pedicels, we saw in the diagram as well. So during splenectomy the surgeon first has to cut these two pedicels in order to remove the spleen. And what are these two? The gastrosplenic, connecting the stomach and the spleen, and the lienorenal ligament, connecting the spleen with the left kidney. Okay, and the contents are to be carefully separated as it holds some very major contents. The lienorenal ligament has the tail of the pancreas, and the gastrosplenic ligaments hold various short gastric vessels, right? When we talk about the splenic puncture, it can be punctured through the left 9th or 10th intercostal space, and a lumbar puncture needle is needed. But when the spleen is enlarged, it can be punctured through the mid-axillary line. Okay, remember this point. Now after splenectomy, as you know, spleen is a secondary lymphoid organ. Okay, so it still has some functions to provide. If you'll totally remove the spleen, the person has some chances to become immunocompromised. Okay, but what we do after splenectomy, the spleen, as it's highly vascular, it's cut into small pieces and implanted within the greater omentum. Okay, the greater omentum, remember, may hold some accessory spleens as well. So after splenectomy, we implant these small spleens into this greater omentum, and because of vascularization, the spleen survives and does its function very properly of producing the antibodies. Again, as I talked about, that it's a major secondary lymphoid organ. Now there is a disease called Panties disease. What happens is in this disease is it's a chronic congestive enlargement of the spleen, which can result in premature destruction of RBCs. Okay, now if the spleen is enlarged, what will happen to the red pulp? The red pulp will become more and more dense, right? So the substance will become dense. Will it be easier for the RBCs to pass through? No. In the first place itself, the RBCs have to squeeze in order to get through the spleen. Now if the substance become more dense, there will be premature destruction of RBCs. Okay. Now again, this is from the Gray's Anatomy. In the clinic, when we talk about splenic rupture, it can occur due to localized trauma to the left upper quadrant of the body, and it may be associated with the left lower rib fractures, right? And as the spleen is highly vascular, we know it bleeds profusely into the peritoneal cavity. Okay, and splenic rupture should always be suspected with blunt abdominal injuries, okay, as it can suffer a major blow due to an injury. Now we talk about the splenic enlargement. As you know, it's an organ of reticuloendothelial system, which has some major roles in the immune system, immunological surveillance, the immune system, and hematopoiesis in some stages. Now, if there is a disease of the spleen, like leukemia or lymphoma, Hodgkin's, it can lead to splenomegaly. Okay, and what are the consequences? It will lead to increased venous pressure caused by congestive heart failure, splenic vein thrombosis, the thrombus in splenic vein, or portal hypertension. Okay, which can further cause various varicoses in certain places, right? The esophageal varicosis, the capute medosi, the hemorrhoids, right? And an enlarged spleen is prone to rupture. In this CT scan also, you can see splenomegaly. Look how far the spleen has extended. Okay, look how down the spleen has extended, right? So this was all about spleen. In the next lecture, we'll take pancreas, and I hope you understood this lecture and got a clear view about the idea and the relations of the spleen and the blood supply, the lymphatic drainage, and the clinical aspects. Okay, so thank you.